For those of you who have not seen the femtosecond laser and it's used for keratoplasty, this is a patient of mine who had previous hexagonal keratotomy, an older treatment for hyperopia. We see here this is the zigzag edge profile, so it starts with a posterior side cut, starts posteriorly, then moves anteriorly, ring lamellar cut, and then this anterior side cut. You see where the air bubble now is broken through, cutting into the glass, and then the creation of these radial alignment marks. You can make anywhere from 4 to 12 of those to help with tissue distribution. One thing I find very helpful is when I use the femtosecond laser, it will cut down to a very deep depth. I know exactly how deep it's cutting. So when I go in with my focal instruments, no financial interest, unlike Rajesh, I'm always very deep stroma. So my success as far as getting a big bubble is much higher when I use a femtosecond laser than when I perform a manual trephination. You'll see that I've reinforced these marks with ink because they do tend to fade. But the eye bank is cutting the donor. I'm the one who cuts the recipient. And the donor cornea also has these alignment marks. So you can ensure perfect distribution of the tissue when using the femtosecond laser, either for a DALK or penetrating keratoplasty. Also, there's this posterior side cut that's at an angle. It's a 30-degree angle, so I don't have to hold my scissors perpendicular to the decimates in order to cut. I can cut along that angle, which for me makes it a little bit safer. One of the nice advantages also of the femtosecond laser, look at that perfect matching of the donor and host surfaces. Because you have this zigzag edge profile, you get this interdigitation of the donor and the host, so you really don't see, off the mic, so you really don't see the step that you can see many times in the traditional DALK performed with a manual trephination technique. Here's that patient whose video we saw. This is about a month after surgery. You know that with a DALK, there's rapid detrojections of the donor cornea. I'll draw your attention here to the wound. You can see the zig and zag right there interdigitating very well. And I have never seen to date, knock on wood, a malalignment of the donor and the host. When I've used that zigzag profile, always the donor and the host meet as they should. The same patient topography, here looking at 3 months. Not all of them have less than a diopter, but of course I'll show you the one that does have less than a diopter if astigmatism is also presumed. So to date, 58 procedures. Most of the patients I'm performing femtosecond keratoplasty for are keratoconics. So the minority of my grafts I'm able to use a femtosecond for, because many of them, of course, these days are endothelial keratoplasty, do a lot of keratoprostheses. And then a lot of patients who have keratoconus are not candidates because the cornea is too thin. And different surgeons will have different cutoffs. I think Roger Steiner will maybe do it for a patient whose cornea is as thin as 400 microns. But for me, my cutoff is 500 microns. And so, of course, in a keratoconic, usually inferiorly where they're the thinnest. So if the inferior mid-peripheral cornea is less than 500 microns, I don't perform a femtokeratoplasty for that patient. We're using zigzag edge profile for almost all the cases. A few other edge profiles, but I think I and most surgeons who are doing this prefer the zigzag edge profile. It really maximizes the surface area of the wound, which expedites the healing. So far, most of the cases have been a penetrating keratoplasty. Many of these patients have corneal scarring and edema, so they're not candidates for endothelial keratoplasty, but whenever we can perform a DALK, we do. So if you're talking about a new technique, you want to mention the results. You're talking about safety and efficacy. So we'll start with safety here. We'll talk about safety as far as intraoperative complications involving the donor and the recipient. So to start with the donor, we only had one case so far with a poor quality cut. Unfortunately, it wasn't mine. It was my colleague Rex Hamilton's. Rex asked me to come to the operating room while he was in surgery to take a look at this donor that had been cut by the eye bank that he thought looked a bit oval. See, a long axis this direction. And I said, yeah, it looks a little bit oval, but how can it be oval? It's a femtosecond laser cutting this donor that's mounted on an artificial anterior chamber. And the femtosecond's got to cut in a perfect circle, so I don't know how it could be oval. I told Rex it's probably just the way it was stored. I said I would go ahead and transplant it. That's not my patient, so what do I care? So he went ahead and transplanted it. This is why Rex should never take my advice. Here the patient is after surgery, 22.4 diopters in astigmatism, which for Rex is pretty good. But I think most of us would find that a little bit high. So I said, no, you know what? Let's remove some sutures. So he took out the sutures and the steep axis and got it all the way down to 11 diopters. So in this case, remove the donor cornea and replace it with another donor tissue. It's only one case, but it does show that you can have sometimes have issues with preparation of the donor, even with a femtosecond laser. As far as recipient intraoperative complications, full thickness corneal incision has occurred in 2 of the 58 cases, so 3%. And here's one of them. When you step on the laser, you should not see these bubbles. When you see those bubbles, what that means, of course, is the energy is going into the anterior chamber. You should stop immediately. Reset the depth for a 70 or 100 microns less posterior. But in this case, I didn't do that. So we had a full thickness trepanation. I took off the suction ring, chamber collapsed, and I had to suture the wound in the laser suite before transporting the patient to the operating room, which was in a different building. I was lucky that that's all I had happen. If you've got an eye that's an open eye with pressure on it with that suction ring, so you could risk an explosive choroidal. You do not want that to happen anywhere, especially in a non-sterile environment such as a laser suite. So that was one of the 2 times that's happened. Loss of suction has happened once. Here's a patient with lattice corneal dystrophy, planning to do a femto-dull. Patient, I can't blame him, he was not squeezing, normal corneal curvature. Watch this fluid meniscus over here. So I'm halfway through the treatment, I'm about to start the anterior side cut, boom, lost suction. So now the question is, do you feel lucky? If you do, you can put that suction ring back on and start the treatment again and hope that the cut intersects the cut you already made. But if it doesn't, if it's malaligned at all, you have non-intersecting cuts, and you're going to have to finish off that zigzag shape with your super sharp blade. And I'm not a good enough surgeon to do that. So in this case, I had to avoid the procedure. Remember I mentioned that I'm having the eye bank prepare the donor cornea. So in this case, I already had the donor cornea. It's not returnable. It was $5,000 US for that cornea, and it was not returnable. So I had to eat that because I was not able to proceed with the surgery. So it's an expensive proposition doing femtokeratoplasty at times. Pore wound closure. Here's a case, another gentleman with hexagonal keratotomy, very steep cornea, over 80 is max K preoperatively. And with the femtosecond laser we're using, the intralegs, it's a flat applanation plate. So you have a very steep cornea, which then you deform by using a flat applanation plate, and then you use a femtosecond laser. So you're distorting the contour of the cornea. And I think what happened here, this is the edge of the donor cornea. Here's the edge of the host, and this is the anterior side cut. So this should be here, but it's not. There's a big gap here. I have the radial alignment marks to confirm I did not misalign the tissue. I think there was such a distortion of the donor cornea, though, during the trepanation, just resulted in a very poor quality match. So I've now learned I really don't consider femtokeratoplasty for very, very steep corneas. If I had a femtosecond with a curved applanation plate, like the Femtech, then I might go ahead and do it. But with a flat applanation plate, I try to avoid these very steep corneas. I also avoid thin corneas. There's a patient with macular dystrophy. Those of you from southern India see this much more commonly than I do in Los Angeles. This patient's corneal chemistry may be 460 microns. This is before I had set that 500 micron barrier. Very hard time closing this wound. Even with a zigzag profile, I do not usually put in that many sutures. Very tough to close this eye. And unfortunately, if you look at the pupil, this is not a dilated pupil mydriatic. This is a blown dilated pupil from high pressure day 1. So the patient ran up with Ehlers-Danlos syndrome, partly because of the high pressure, because I have trouble closing this wound. The patient ended up with sutures out, 6.9 diopters, not so good. But in this case, the femtosecond laser saved me because I performed a femtosecond astigmatic keratotomy. Got the astigmatism down to 1.8. So, good save there. As far as poor quality cut, I think the way you can avoid this is by having the eye bank do the cut. If there's a problem, just as with DSEC, it's their responsibility, not yours. Also, I have found that in the areas where there's epithelial irregularity, that is often the area where I've had a poor quality cut of the donor cornea. So I often ask the eye bank to debride the epithelium if it's irregular to ensure a good quality cut. As far as the recipient, to avoid full thickness corneal incisions, repeated ultrasonic tachymetry. I leave about 70 to 100 microns of the posterior cornea uncut to avoid a full thickness cut in the donor. To avoid loss of suction, I trend that not consider patients with very steep corneas to be candidates. And as far as the poor wound closure, as I mentioned before, I avoid very steep corneas and very thin corneas. In the little bit of time I have left, I want to just touch on efficacy, the other part of evaluating any new technology. Looking at topographic astigmatism first. Here are the results with all of our femtokeratoplasties for all indications. The topographic astigmatism at a month, 3 months, 6 months, and then 12 months. But we're going to evaluate this. We need to compare it to manual keratoplasty. So to compare apples to apples, I looked at my patients with keratoconus and compared the femtokeratoplasty group, which is in red, to the manual keratoplasty group, which is in orange. We can give you just about a minute and I'll finish up. And you'll see that preoperatively, the group who had the femtokeratoplasty in it was starting off about 2.6 diopters steeper, and postoperatively about 1.3, 1.4 diopters steeper. So there's a greater flattening effect when you use a femtosecond laser, in part because the donor is not oversized. You use the same size diameter for the donor trephination as you do the recipient trephination. Topographic astigmatism, probably the most important thing to us. What is the amount of astigmatism in these two groups? We can see that there's no significant difference other than at 6 months. There's significantly less astigmatism in the femtokeratoplasty group as compared to the manual keratoplasty group. But at a year, it's exactly the same. Why do we see a difference at 6 months that goes away? It's because we start suture removal earlier in the patients having femtokeratoplasty, an average of 3.5 months after surgery, as compared to the manual keratoplasty group, where it's 5.4 months. But when you get out to a year, then the astigmatism is determined not necessarily by the means of trephination, but by the suturing. And that's why we saw no difference between those two groups. As far as visual acuity, we didn't see any difference between the two groups, no significant difference. As far as corrected distance visual acuity at 6 months out, again, femto in red, manual in yellow. But we did see a difference in, however, the amount of astigmatism required to give the patient their best corrected vision. So here we're looking at refractive cylinder at 6 months. We see a greater percentage of patients who had femtokeratoplasty who have 2 diopters or 3 diopters or less astigmatism as compared to those who had manual keratoplasty, although the difference was not statistically significant, maybe with a greater N if appropriate. So there's multiple advantages to using the femtosecond laser for keratoplasty, both penetrating as well as dull. In my hands, I said, really facilitates dull because it gives me a very controlled incision depth. The very deep incision minimizes emphysema of the peripheral cornea, and the wound configuration enhances matching of the donor and host surfaces. It does have disadvantages. It's more expensive. You can risk vacuum loss, full thickness incisions, and poor wound closure, as I've showed you. But also, many patients are not candidates because of anatomic features such as an overhanging bleb that make it difficult to obtain suction on this eye. And I tend to avoid doing this in patients with previous incisional corneal surgery, which I have to cross the incisions, such as patients with previous parquet surgery or previous penetrating keratoplasty. So in conclusion, while the femtosecond laser offers several advantages, such as more precise incision creation, the disadvantages have really limited its use both in the United States and I think internationally as well. So I think right now it really remains to be seen whether this represents the future of incisional corneal surgery or just a passing fad. Thank you very much for your attention.